So we are going to discuss a basic principle of urology surgery, and today we are discussing a very basic principles in the urology, which includes incision, suture material, and the drain placement.
Assalamu alaikum. I'm Dr. Adil. This presentation will be more, the moderator of this presentation will be Dr. Kavalnas. So the topic is principles of urologic surgery, and the learning objectives are incisions, drains, sutures, and wound closure. We have tried to make it an interactive session because we are doing these things routinely in our practice. So anybody has any idea about the common incisions used in urology?
So these incisions you are given for the which kind of surgeries?
In this era of minimal invasive surgeries, where laparoscopic and robotic surgeries are very common, open surgeries are less preferred in today's world, but they're still important. They have certain indications for open surgeries as well. So, talking about the approaches to kidneys, there are various approaches to reach the kidneys. So, what are the open approaches to kidneys? Incision
And through flank incision, we are mostly performing the retroperitoneal and exactly anterior and the flank incision use. So, what are the importance of the incision? Why we are discussing it? Exactly, for the best approach. So, if the incision is not good, we are struggling with the structures and we are struggling with doing the surgery.
So basically, there are two approaches for kidneys that are anterior and flank. So anterior approaches the kidneys and the retroperitoneum. So in this diagram, there are various incisions. They have been marked. Anyone would like to tell?
Name these incision.
Number one is midline incision,
Yes.
and number two is Cocker incision.
Yes. Walker subcostal.
Number three is chevron incision.
Yes.
And number four is thoracoabdominal incision. And number five is flank incision.
Transversion.
Number six is pyramidal incision.
Good.
So these are the incisions, as rightly told by Dr. Kamran. Midline incision, subcostal, chevron, modified thoracoabdominal, transverse, and pyramidal. This diagram shows the various flank approaches that we can use for to reach the kidneys. And these include 12 rib supracostal, 11th rib transcostal, thoracoabdominal, polymuscle splitting, and flank subcostal incisions. So we'll talk about the basic anatomy of the retroperitoneum. This is an oblique view of the retroperitoneum, is showing various structures. On the right side, we can see the kidney, the overlying part of duodenum, and this pararenal space with pararenal fate, fascia transversalis, and posterior parietal peritoneum. These structures we most commonly encounter on the right side. And similarly, on the left side, there's we can see the aorta, the great vessels, and the superior mesenteric vessel, and descending part of colon, and splenic hilum, as well as the tail of pancreas that will be encountered while dissection on the left side, and the retroperitoneum for kidney excision. So these are the various approaches used for kidneys excision, anterior flank, that we'll be discussing shortly. So talking about abdominal incisions, they could be midline, which could be a full length midline incision, or the lower midline or upper midline incision. So the midline incisions are commonly used to access the extraperitoneal or peritoneal and retroperitoneal spaces. Lower midline is also infraumbilical. Its indications include radical retropubic prostatectomy, simple prostatectomy, pelvic lymph node dissection, cystectomy, diverticulectomy. and enteric cystoplasty, urinary divergence, specimen extraction, post laparoscopic surgeries. So upper midline used for access the retroperitoneal structures bilaterally. Yeah, the indications include bilateral nephrectomies, resection of retroperitoneal masses, trauma nephrectomies. So the length of incision can vary depending upon the procedure that is being performed. Small incision like 2-3 centimeter can be given for suprapubic lithotomy, or a complete midline incision can be given for extensive procedures. So the basic technique is identify and palpate the linea alba, incise along the linea alba to avoid rectus abdominal muscle injury, and closure is usually uh, performed using interrupted or running one layer running or interrupted figure of 8 with strong two synthetic microfilament absorbable sutures. The continuous closure is avoided with rapidly absorbable sutures to prevent higher hernia rates. So this is anterior approach. There's a Gibson incision. It's traditionally used, as we have seen in transplant surgeries. It provides extraperitoneal access to pelvic vessels, lower ureter, and the bladder. The technique is an oblique or curvilinear incision is given from the medial to anterior superior iliac spine, extending above the symphysis pubis. So the recent modifications are the incision is given more like in a J-shaped or hockey stick incision. The splits the external oblique, internal oblique, and transversus abdominis muscle. Two-layer closure is advised with running absorbable sutures for this incision. Another anterior approach is thoracoabdominal. It provides exposure to the thorax, retroperitoneum, and blood vessels, and it's mostly used in oncological surgeries. That's a very complex surgeries, including thrombus of IVC that's extending up to level 3, T4 renal surgeries, upper pole tumors, renal, and retroperitoneal masses. So the position, as you can see in the diagram, the patient is in exaggerated flank position. Incision is given above the 9 to 10 rib, extending into abdomen, and there are modified forms of this incision include the incision is given through the 8 rib combined with the subcostal incision. So the complications that we can encounter while giving this is
What are the complications of the thoracoabdominal incision? Disadvantages are most common complication. Dr. Asad?
As we are involving the thorax, so most common complication is pleural injury,
Exactly.
and if we are having thoracotomy on the right, on the left side, then there is heart on the left side.
I will go for the thoracotomy.
Thoracoabdominal incisions.
Thoracoabdominal incision, then what will be the damage to the heart in this
So
incision?
if the patient, if the surgeon is inexperienced,
Okay.
he does not know the delineation of the incision, so he may encounter these complications.
Okay. And what are the advantages of this incision?
The advantages includes the if we are operating on a large adrenal mass, so it can give you a good exposure and
Easy access to the upper pole of kidney and the upper
Yes.
administration.
So the care should be taken to open pleura that from and it goes to counter junction. As we know, the pleura can extend from anywhere from the 10 to the 12 rib. So care should be taken to and avoid injury to pleura. And this is closed usually with or without chest tube. Diaphragmatic incisions are closed in 2 layers with running absorbable sutures. chevron or subcostal incision. We have most commonly seen here in tumor surgeries. This is basically utilized for anterior tumors that can be extended toward. So when we see the tumors extending up to the chest or including the blood vessels, it can be modified into with a midline sternotomy, also called the Mercedes-Benz incision. So incision is basically it could be a hemichevron or a chevron incision. So basically subcostal incision. It's started from the tip of 11th rib and it extends and in the midline, that's below the xiphoid process. And it can be modified for external access for the chest access with midline sternotomy. It provides very good exposure for extensive procedures are, for example, vena cava thrombus. And then there are flank incisions, which we routinely use here in benign as well as tumor surgeries. True flank incisions, it could be supracostal above the 12th rib, transcostal 11th rib, or the subcostal. It is used to access the posterior retroperitoneum, the risk of thoracic complications as well as the rib pain. The incision technique is when we are talking about the supra 12, we start from the tip of the 12th rib and then extending medially to the lateral border rectus, and then we divide the muscle layers that include the external oblique, internal oblique, and transversus abdominis. And then there's a window we create, we usually, and then we save the peritoneum as well as the pleura is saved using careful dissection. Usually we use diathermy, so we're starting from the tip of the 12th rib and then we extend posteriorly to avoid injury to a pleura. So the incision is usually closed with running absorbable sutures, and if there is pleural injury, we close it primarily, or we can insert a chest tube when there is extensive injury to the pleura. So there are other incisions used in as urological surgery that are inguinal incisions that are used for pathologies like radical orchidectomies, or the incisions could be above the inguinal ligament that are used for radical orchidectomies. Benign disease for use smaller incisions above the external inguinal ring, as shown in this diagram. And the subinguinal approach is used with prior patients having prior surgeries that avoids injury to the ilioinguinal nerve and spermatic cone. So inguinal and pelvic lymph adenectomy is standard subinguinal incision is used for this disease for extensive dissection and lymph node removal in the penile cancer. So these are various incisions that are used for lymph node, inguinal or pelvic lymph node dissection in the penile cancer. As we can see, the incision A is a midline incision, allowing for access to for superficial and deep inguinal lymph nodes, and B is vertical incision for access to superficial and deep inguinal lymph node, and then this S-shaped incision is given for complete inguinal lymph node dissection and ipsilateral pelvic lymph node dissection. We can also give Gibson incision for ipsilateral pelvic lymph node dissection, and then there is a common subinguinal incisions for ipsilateral lymph node dissection. And then there are another approaches used for pelvic lymph node dissection or inguinal lymph node dissection include these incisions, bilateral inguinal lymph node incisions. They can be given in a subinguinal region. So there were various pathologies where we use scrotal incisions that includes varicocelectomies, hydrocelectomies, and spermatocelectomies and vasectomies. Scrotal explosion for testicular torsion, orchidopexies, insertion of penile prosthesis or artificial urinary sphincter. There are a few certain contraindications for scrotal surgeries that include presumed testicular or intrascrotal malignancy that should be accessed via the inguinal incision. The incision could be transverse or vertical on the ipsilateral side. When there's bilateral pathologies, we usually use the midline vertical incision in the median rapid. Please.
There is a contraindication of the scrotal incision when there is an intertesticular malignancy. And if we give the if we give the scrotal incision, then what is that called? तो पता है? कौन पता है?
इसका वर्ड क्या नेम यूज होता है?
There is scrotal malignancy, testicular tumor, okay? And you have given the scrotal incision. So then what is that called? So क्या कहते हैं? इसको बताइए.
जमाल,
हाँ यार. तो क्या कहते हैं भाई?
AZM Rose
That is called scrotal
violation.
violation. क्या कहते हैं? Scrotal violation. If there is a testicular tumor and you have given the incision at the scrotal region, then that is called scrotal violation. क्यों?
It may leads towards heating of the skin.
Our scrotal. That's it.
Basically, it will disrupt the lymphatic supply as well. As a result, the tumor will spread to the inguinal lymph nodes as well. So basically, the lymphatic spread will be there in case of scrotal violation.
That is supply of the testicle goes towards कहाँ जाती है? Perineal lymph node. And scrotum की कहाँ जाती है? Inguinal lymph node. If you have given the incision at the inguinal, if you have given the incision at the scrotal region, then you have done the scrotal violation, and then the lymphatic channels of the inguinal region will be involved. तो आपने कभी भी incision नहीं देना, कोई सीनियर भी कहे तो भी incision नहीं देना, ठीक है? तो अल्ट्रासाउंड पे अगर आ गया कि testicular tumor है, then you will go for inguinal treatment, okay? कोई भी नहीं करेगा, अभी भी दिया हुआ है बगैर किसी ठीक. तो ये स्क्रॉटम में कौन सा इंसिजन देना चाहिए भाई? बोलो ना, बोलो, इनको एंगेज करो. इतने सारे बेड में किसी को इंटरेस्ट नहीं होता भाई. कौन सा इंसिजन देना चाहिए? ये कौन सा इंसिजन दिया हुआ सही है या गलत है? स्क्रॉटम क्या क्यों बैठते हो?
अब्दुल कयूम या कामरा.
ये ठीक है या गलत है? हम कौन सा देते हैं? कौन सा देना चाहिए?
डिपेंड करता है सर्जरी कौन सी करनी है और
डिपेंड नहीं करता है. हाँ.
ट्रांसवर्स देना चाहिए, उसकी ब्लड सप्लाई जो है वो उस तरह होती है.
लेकिन अगर आपने बायोलेटरल करना है तो आप कितना दे सकते हैं? कोई हार्ड एंड फास्ट रूल नहीं है, लेकिन जो है वो यूजुअली recommendation is you have to give the horizontal incision. Okay.
So the closure includes the layer-wise closure, and the goal is to prevent the dead space, to prevent swelling and hematoma formation. We can use a Penrose drain or closure is done with 1 or 2 layers, including the Dartos layer with absorbable sutures. Skin is closed with interrupted or horizontal mattress sutures. Penile fractures, they are common. They can be explored using 2 approaches. There could be degloving approach with a circumferential subclonal incision, or we can alternatively use direct longitudinal incision. Potentially, this is mostly like favored for better return to sexual functions.
You have to give for penile फिनाइल फ्रैक्चर कौन बताएगा? एक बता दो देखो, नए वाले बताओ। रिया बोलो यार, you have to speak up, you have to remove your fear from your heart, so you have to speak up. उनको बोलो, बोलो को समझ नहीं आ रहा बोलो, उल्टी सीधी बोलो, कुछ भी बोलो। अगर आप नहीं बोलेंगे तो you will not get the third prize in bounce. थर्ड प्राइज भी हासिल कर सकते हैं, किसी ने भी नहीं किया था। हाँ हाँ ठीक है, तो we have to deglove.
Deglove दो।
सबक्लोरल इंसिजन देके we have to deglove. नीचे से सबक्लोरल नहीं देना, नीचे से किसी ने एक दफा base of the penis, this is wrong and one consultant has, I think. So we have to deglove whenever there is a penile fracture. We have to deglove and then we see where the fracture is there, and ultrasound will help us. Or there is a bleeding. If you have deglove, then you will remove the bulb fascia. Then there is a bleeding from the papilla. We have to repair it. So for penile fracture, we have to deglove. Right?
So then there are perineal incisions. They're commonly used for uteroplasties, perineal uterostomies, male uterus slings, inflatable penile prosthesis, artificial uterus sphincters, and radical perineal prostatectomy that is rarely performed now. So perineal incisions could be the inverted Y shape, this is called Mercedes perineal incision, or it can be usually given in the midline perineal incision to access the bulbar and posterior urethra. So the vertical midline incision is usually given that is 8 to 10 centimeter beginning at the perineal scrotal junction. Another type is inverted Y or lambda incision that has higher complication rates and that's less preferable. So closure is again multi-layer depending on the dissection extent. Collis fascia closed before skin. Skin is closed with interrupted mattress type sutures. So let's summarize the incisions that we have discussed. Then if there's a patient with a 15 centimeter upper pole mass of right kidney, what kind of incision should be preferred?
उस्मा खड़े हो, जोर से बोलो।
Thoracoabdominal approach के
और right side का ट्यूमर है।
chevron.
Exactly. What we commonly give in which incision? Midline lace likely used for the kidney tumors.
What is recommended for the upper pole tumor? If there is a huge upper pole tumor, which incision?
Thoracoabdominal.
It's a flank incision. Super 11, super 10. Okay. So it's a flank incision. There's no chevron, only the flank incision is preferable for the upper pole tumor. Okay, आगे. सही है ना?
जी सर, लेकिन हम chevron दे रहे हैं।
So if there is a similar mass on the left side, again, what kind of incision should be preferred?
So what is the difference between the right-sided surgery and the left-sided surgery? How will incision change on the both side? And why? What kind of position? Why position is different on both kind? Basically, on the right side, there is a liver. So for the retraction of the liver, we have to extend our incision. That's the reason we are mostly using oncological theater, the chevron incision for the right side and the thoracoabdominal for the left side.
I think for upper pole tumor, the flank incision.
And is the good because
It is written in the EU guideline that you have to give the flank incision. IVC में thrombus है, तो फिर क्या करेंगे? Depending on the level of
thrombus.
So आप कौन से levels होते हैं? कैसे define करते हैं? What are the levels of the thrombus in IVC?
Dr. Faiz?
ये वाला बताओ।
हाँ, senior.
वो तो ना level 1 कहाँ होना चाहिए? अकल क्या कहती है? Renal vein में it is not extending to the IVC. नहीं, तो level 1 कहाँ होता है?
Renal
Renal
vein.
vein. और फिर उसके बाद फिर जो है वो level 2 कहाँ होना चाहिए? Liver से नीचे, IVC liver से नीचे. Intrahepatic part of IVC. Level 3 कहाँ होना चाहिए? Intrahepatic part of IVC. समझ गए? Level 1 in the renal vein. Level 2 intrahepatic part of IVC. Level 3 intra-hepatic part of IBC, and level 4 supra-hepatic part. Superior vein in the cava. Okay, and heart में जा रहा हो तो वो level तो जब ये हो तो क्या करना चाहिए?
Next question.
चलो अगला
Bilateral adenectomies.
अगर अगर जो है वो level 4 नॉर्मल है तो फिर क्या कौन सा इंसिडेंट एक नाम है गाड़ी का
Mercy.
मर्सिडीज बेंज है ना जैसे पढ़ा
An incision for the bilateral adenectomies if you are doing the surgeries on the both side. Any other incision we can give? Midline. So recently we have discussed 8 centimeter renal mass with level 3 IVC thrombus. Which incision we give further? And सर सबने देखा यही ज्यादा है ना
आप फ्लेक्सिबल रहें
Again, it's all depend on the patient's condition. If the patient has multiple metastases or if it's a tumor fractures, we cannot give make the flank position, so we can go from the midline. It all depends on the condition of the patient and at that time what we are doing, what is the intention of the surgery.
we have to go for
Third.
psychoanalytic or medical okay तो अगर बहुत ज्यादा फैला हुआ अगर एक दो मेटास्टेसिस है तो then we have to go for psychoanalytic if multiple metastases in the pleura in the lung in the
Bones.
if metastasized then we should not go for surgery we have to do we can't do the surgery in this case okay and we have to go for medical so oligometastasis with RCC we have to go for cytoreductive nephrectomy यही है person
जी sir.
and if there is a multiple metastasis we have to say sorry we can't do the surgery in this case okay
Sorry. And
So-
we mostly use simple nephrectomy of non-functioning kidney.
we should not give incident for this patient
Yes.
we have to go for
Laparoscopy. Exactly.
इनमें से किसी भी incident नहीं रहना चाहिए आपको laparoscopy करनी पड़ेगी
सर उसमें भी इंसिशन आएगा
और फिर भी laparoscopy करनी चाहिए क्योंकि अभी सब रोबोट से करते हैं या laparoscopy ओपन कोई नहीं करता कोई नहीं इवन रीडू सर्जरीज भी रोबोट से होती हैं स्पेन में
यूथ्रोप्लास्टी तक भी रोबोट पहुंचा नहीं है So 3 centimeter stone in the upper ureter. Dr. Zakaula.
अपर यूनिट में चलो ठीक है हम पाकिस्तान में तो कौन
No, we are talking for the open surgery, so let's. Yeah. RI is not in open surgery, Dr. Kamran. Flank, subcostal flank incision.
और चलो आगे बढ़ो।
3
And the
centimeter
same stone in the lower ureter then. Good. For the ureteric implant,
Gibson incident is सबसे important आपने Gibson incident किया you have given the Gibson incident and there is a 1 liter blood in the brain आपने क्या मिस किया है
कौन सी? Inferior epigastric artery.
inferior Gibson incident में inferior epigastric artery जरूर आएगी
हाँ, और उसको
If
tie
you are
करना
giving
होता है.
the Gibson incident then there is an inferior epigastric artery which is the branch of
External.
External eye.
So there is a heavy feeling if you will cut the epigastric artery and it will be missed in the muscle. So you have to tie inferior epigastric artery and vein as well. So Gibson incident है आपने जरूर नजर आएगी आप अगर सही डायरेक्शन करेंगे
मादा दर्द की वजह से वो करने का एक मानना है
So where does in the week process the markets keep on reacting
Dr. Nadia, Dr. Bakhtavar.
बता दो
तुम्हें बताइए.
blood transfer से बताओ जब आप फेशियल बोलते हैं और फिर उसके बाद जब मसल की परिणाम होती है तो आपने जरूर इसको जो है तलाश करने आपसे जरूर खाए बहुत सारे लोगों को नहीं मिलती ये मिलती इसलिए नहीं कि हम देखेंगे
Apart the undescended tests, which incision? Sorry. Or
और अगर abdomen है तो
laparoscopy. उस प्रोसीजर का नाम क्या है?
कौन कह कोई कह रहा था कौन कह रहा है
इज़ाकाउला बता रहे हैं.
हाथ पकड़ो और खड़े हो जाओ बताओ
कोई डांटेगा नहीं यहाँ पे.
Stephen Fowler 1 and 2 ठीक है
So 1 में हम क्या करते हैं और 2 में क्या करते हैं?
1 में हम टेस्टिकुलर आर्टरी लाइगेट करते हैं और गैबर्निकुलम सेपरेट करके उसको मोबिलाइज सुपर डीप इंग्वाइनल रिंग में लाते हैं वहां ताकि लेंथनिंग हो स्टेज 1 में
सही है.
और स्टेज 2 में स्क्रोटम में लाते हैं और क्योंकि उसकी 3 ब्लड सप्लाईज होती हैं टेस्टिस की तो टेस्टिकुलर आर्टरी वहां पे हमें लाइगेट करनी होती है
सही. चलो आगे चलो.
So,
So now the second topic is the drain. Any
Uh,
question regarding the incision?
So there is a controversy among various surgeons regarding the routine use of drains, and they are usually recommended when there are absolute indications for drain.
What is the importance of the placement of drain? Dr. Bakhtavar? So if we not place the drain, what would be the happen with the reactionary fluid? So drain is protective or indicative? That if the drain will prevent from the bleeding or it will indicate that there is a bleeding or there is a source of the collection. What are the other advantages of drain? बोलो भाई.
Have both. Whenever we using drain like as a nephrostomy, it will also give the tamponade.
Exactly. Sorry.
So drains are usually classified as open non-section, closed non-section, and closed section drains. Most experts caution against the routine use of drains. So open non-section drains are used when there is when accurate quantification of the drainage is not as needed, associated with less patient discomfort, and they are easy to remove. These include closed non-section drains. Examples are Penrose drain, that is a soft, flexible latex or silicone rubber available in various sizes from 1/2 inch to 1 inch in diameter. Suture is suture to the skin to prevent migration. It drains into the dressing rather than any collection bag, and it is associated with higher infection rates. So closed sections, the drains, they utilize negative pressure, and it helps immediate recognition of small amount of drainages that include Jackson part drain, that is also called JP drain, and black and drain and pigtail drains. Uses are commonly in scrotal surgeries and to prevent fluid accumulation in the subcutaneous tissue. JP drains are usually a closed system with a grenade-shaped bulb and internal tubing. It creates negative pressure to draw the fluid from the surgical site. It's usually used in abdominal surgeries, minimizes risk of infection as compared to the open drain. It's usually placed through a separate incision, and it can cause more patient discomfort as compared to non-section drains. And pigtail drains, they are again closed drainage system with curved.
So, what are the uses of pigtail drain? Where we use in our daily practice or in our emergency situations? You can use
इसके नाम लोगों को बताएं
Dr. Nadia.
Drain.
Yes, and Alia. Exactly, pleural pigtail we also use.
So they can be also attached to a negative suction valve to create negative pressure as well. usually used in the drainage of abscess cavities or organ spaces. Then the third and last topic is the suture materials that are routinely used in surgeries.
So, what are the qualities of the suture when we are uh, asking for the suture from the assistant? So, what are in our mind that that suture will be particularly used for at that moment or not? Dr. Asad, please, mic le le.
Oh.
Mm.
The quality of sutures, it depends upon the tensile strength as
Exactly.
well as the, absorbability.
Yes.
We encounter absorbable as well as non-absorbable sutures, like silk that is non-absorbable, and the Poroline as well.
So
Uh,
basically, when we are using any suture, there's certain things in our mind that the tensile strength of the suture, tissue reaction, and the absorbability and knot placement that either it will be an easy knot tying or not. And the second thing is absorbable or non-absorbable, because if you use the non-absorbable, there will be the chances of stone formation in our urinary system. So these are the common sutures we are using in our daily practice. Dr. Adnan, suture, what is the E? E is proline. दोबारा गौर से देखो. It is, I think, purple color. Purple है. And what is in B? Yes. And C? Rapid victor. And what is this suture? Black in color. Silk. So what is the properties of silk? Where we mostly use it? Only for drain. दोबारा सोच लो. Exactly. जी अब्दुल कयूम. Ligation of what? Yeah, okay. We use for the renal and arterial ligation and for the drain placement. And B,
So these are the suture characteristics, and these include the suture size, filament structure, surface texture, tensile strength, degradation property, and stiffness, as well as flexibility. Though the standard sizes for United States is 11.0 to 6, and the European for is 0 to 1 to 8. The sutures can be multifilament, monofilament, and pseudo-monofilament. That can be again braided, higher mechanical properties, having excellent banding properties, rough surface, more microtrauma in tensile tissue drag, high inflammatory response, susceptible to bacterial infection. So these are basically could be absorbable and non-absorbable, and then again they are could be monofilament, multifilament, and barbed sutures, absorbable as well as non-absorbable sutures.
So what are the example of the absorbable suture? Dr. Adnan? Yes. G? Okay. And the non-absorbable sutures? And silk, proline, stain. Okay. So these are the
Recommended sutures for various skin and other incisions, cosmetic closure. Then for the adult is absorbable, size could be 40, and for the pediatric is 50. Non-cosmetic options include staples, non-absorbable sutures. They can be 40, 30, and for peds 50 or 40. Fascia is usually closed with PDS or Maxlon safe. They could size 0 for adults and PDS 30 for the pediatric population. Muscles is usually used with absorbable sutures, and bladder again which is used absorbable sutures 30 or 20, and in peds we use 40 or 30 sutures absorbable. And then the ureter pelvis again absorbable sutures can be from 40 to 50 in adults and 5 or 60 in the pediatric population. And the urethra for vascular absorbable sutures we use PDS 4050 or in the peds 5060. And for bowel, we can use staples or absorbable for inner layer 3040. And for again in pediatric population from 40 to 50. And for the vascular ligation, we use non-absorbable or 40 to 50. And in pediatrics again 40 to 50.
Who have done the vascular rotation? कौन सा प्रोलीन? सही, ठीक है.
So
पाइलोप्लास्टी में हम कौन सा सिस्टर यूज करते हैं?
which
बताओगे?
size, right?
3 or 4. सही. आगे
And then the urethroplasties.
यूरोथ्रोप्लास्टी में कौन सा यूज करते हैं? पीटीएस कौन सा? और कोई यूज कर सकते हैं या सिर्फ पीटीएस से ही आईवीसी रिपेयर के लिए अगर इंजरी हो जाए हमारी यहाँ में इसको? सही. एब्डोमिनल शीथ क्लोयर के लिए वाइक्रल हमने लूप के लिए जो जिसकी स्ट्रेंथ ज्यादा हो, टिश्यू रिएक्शन कम हो, हर्निया से प्रिवेंट करें. थैंक यू.
Thank you.